So when we talk about the brilliance in the diabetes, so this is our today's agenda, and so we'll discuss the prevalence and revised guidelines, clinical studies, and the therapeutic options. Although this is a very conventional kind of, I will try to discuss those things which are not discussed most commonly, but I may take few more minutes with the kind permission of Dr. Tahir Chaudhary. And where are we? Kahan khade hain hum? So this is the question, this is the problem, where are we? So where are we? It means that what is the present scenario? You all know this has become an epidemic in this part of the world. Very unfortunate. Those areas where you have maximum prevalence, that this is the area, this is the dark area, and I think the darkness is prevailing, and we are among the top ranked countries having the diabetes. So what is the burden of the diabetes which we are carrying? So burden of diabetes is such that Pakistan, when I started my practice, Pakistan was ranked 7th in the world. So with a span of few years and within a span of 1 or 2 decades, the prevalence has raised, Pakistan's position has gone up. Might not be in the cricket, but now the Pakistan has gone the 3rd in the world. So we are having around 33 million of the people with diabetes. And still the situation will be the same. There will be no change in the situation, but the population of the diabetes would be 62.2 million. So I think, but this is the projected rate of our prevalence is 2045. I think we are going to touch this around 2000, around more 2040 or 2035, inshallah. So this is a problem which we are facing. Why we are having this, you know what is the reason behind. And Pakistan is among those countries who are having the highest prevalence rate of diabetes. And you know, we are sitting in this hall, every 4th person is having diabetes, adult is having the diabetes. So this is the dilemma. The diabetes this is not the raised glucose. It means that you are harboring the complication in your bag. And Pakistan, another tragedy is that 8.8 million people, they are diabetic, they are undiagnosed. And moreover, a large number of population, they belong to the strata having the pre-diabetes. They are the potential diabetic. Sooner or later they will become diabetes. So this is another problem which we are facing. So what is the impact of this diabetes? So people with diabetes, they have cardiovascular disease, they die earlier than the normal population. So what it has been, so this is a normal lifespan of a person, that from the childhood to the end of the life. So if you have diabetes, if you don't have the diabetes, so you have the lifespan like this. But if you have the diabetes, so you have reduction in the 6 years, you minus 6 years from your life. But on the top of it, if you are having cardiovascular disease along with it, you can minus 12 years from your life. So this is the great problem, because the person who is the breadwinner of the family, and he is having the high risk of cardiovascular mortality. So this is the great issue which we are facing with the lack of the background medical facilities. We are not having the network, and it is also the government is not contributing anything on it to prevent for this deadly disease. So what is the relationship with the cardiovascular disease and the diabetes? So major cause of death in the diabetes is the coronary artery disease is 2 to 4-fold more among the diabetes. Similarly with the stroke and heart failure is 2-fold more high in these patients. So this is a bi-directional relationship. The patient with heart failure, they are having more chance of having diabetes, and the patient who are having diabetes, they have more chance to have the heart failure. So if the person is the smoker, so you can multiply this factor with the factor 4 or 5 or 6, whatever. So smoking also contributes to this high risk of coronary artery disease. So this is the thing which you have seen multiple times, the ominous octet. 8 जो मनहूस चीज़ें हैं वो क्या चीज़ है. Previously when we were student we are thinking that probably the diabetes is because of the lack of the insulin, the beta cell are not producing enough insulin, that's the one of the reason, or moreover there is insulin resistance. Third, we have more hepatic glucose output. So we are having 3 confounding factors, probably they are contributing to diabetes. But with the passage of time, with the increased research, now the ominous octet. But some people, they are blaming 11 factors as well. I will not discuss those factors, 11 factors, but the 8 ominous octet, the ominous octet means the 8 factors. So what we have the new players in the pathogenesis. Like we have not, the role of alpha cell was not studied before the invention of the DPP4 inhibitors. So it has been studied that the alpha cells, they are hypertrophied in the diabetic patient, they are producing more glucagon. So they are more contributing the glucose and hepatic glucose output. The role of incretins was, again it was studied because we are deficient in the incretins, the diabetic patients are deficient in incretins, so that also contribute to the hyperglycemia. And we have increased lipolysis responsible for the cardiovascular disease, and very interestingly the increased glucose reabsorption from the kidneys. The role of kidneys has been very much in the pathogenesis of the diabetes. So we are having more glucose, it also contributes to hyperglycemia. We have decreased glucose output from the muscles and increased hepatic glucose output action. So insulin, decreased insulin secretion is there. So all these confounding, 8 confounding factors, but some people think there are 11 factors, but 8 are proven factors that they are causing the pathogenesis, they are responsible for the pathogenesis of diabetes. So what is the benefit which we get? This is the lesson, you might have seen this slide multiple times in your in different conferences, that single digit, if you improve the A1C by 1% with a single digit, so how much benefit you can get. But you have more benefits. This is the lesson which we have learned from the DCCT trial and UKPDS trial. The maximum benefit we had, the microvascular complication, they are reduced by 37%, and only macrovascular complication which is benefited most is the peripheral vascular disease. The rest of the things, they are changed, but obviously they are not so, the p-value is not significant in these things. So what is the clinical inertia? Why we are so slow? हम तब्दीली को कबूल नहीं करते. Why we are slow? There is inertia. So at times, so it has been studied at the initiation of the insulin, almost 5 years with the A1C more than 8%. So you don't start insulin, and we have studied, one of the study which we conducted, so it takes almost 9 to 10 years before the start of insulin. So the inertia at the level of different levels, inertia at the level of physician, inertia at level of patient as well. So, and you know why there is inertia, why you need the change, because diabetes is not a static disease. It will be not the same disease which we are having today, which we are seeing today. It will be the totally different disease 5 years down the road. So we have to change, we have to amend the treatment accordingly. So we have, so obviously the 50% of the beta cell functional capacity is gone when you are diagnosed diabetics, but the foundation of complication is already laid down before the clinical onset of the diabetes. So that is why that you have to start the treatment at a very early stage, even from the day 1. And this is a classical example of inertia, that when you are planning to start insulin, what do you have? So you have inertia on the side of the physician, that physician, their barrier concern about the weight gain and about the hypoglycemia, patient भाग जाएगा, सुई से डर लगेगा. So this is inertia. Patient thinks it's a weight gain, probably his diabetes has become more worsened, and lack of family support and sense of failure and lack of confidence. And you don't know, even the doctors, they don't know how to start insulin, family care, physician, but with the help, I think because of the multiple conferences and workshops conducted by my dear friend Dr. Tahir Chaudhary, now the people much aware about the insulin. But insulin is becoming, their role, it has become a little bit less compared to the other factors. So what are the barriers? So we'll discuss. So these are the barriers. in the clinic. So these are the barriers for better control, because therapeutic inertia, we have just discussed, we don't intensify the treatment at proper time. We are scared about the side effects, burdensome regimes, fear of injections, negative appraisal of insulin, poor communication. I think the pure communication, now the AD has included one segment, the language matters. Language matters. What is your ledger to the patients? How you communicate to the patient? This is very important. If you are not communicating patient, you are not conveying your message effectively, obviously your message will not be conveyed and the patient will not in a position to start or intensify the treatment. But what is the solution? Either you have the improved therapies, which we are having mostly, and diabetes self-management education program. It has been conducted by the ADA, and it is the mobile app is available. Improved devices, injection techniques are good, and support from the psychologist. This is very important. We've been practicing in our setup that we have a psychologist with us, and they teach the patient, they counsel the patient regarding their problems. And nurse-led management, I think this is one of the solutions. If you have that trained diabetes nurse, it can play a very supportive role. So these are the solutions which we are having. So do you agree with the statement that this is a statement, the A1C target is less than 7 for everyone with diabetes? Yes or no? हाथ खड़ा करें, पता चलेगा. You agree? Everyone should have the A1C less than 7%. No? No वाले हाथ करें, yes वाले. अच्छा. अभी दूसरी स्लाइड से आपको पता चल जाएगा. नो, ये आपने स्लाइड दूसरी देखी हुई है काफ़ी दफ़ा. So what we see that if you have, we have more stringent criteria, because if you have disease duration, newly diagnosed patient, go very tight. This is a lesson which we have learned from the UK PDS. If you control the hyperglycemia from the day one very effectively in a patient, so you have the legacy effect. You have the metabolic memory even down the road. If you lose the other parameters, or your treatment is not up to the mark, even then you are free from the complication. If you have life expectancy which is long, very short life expectancy, बूढ़े बंदे के अंदर इतना आप tight नहीं जाओगे. If you are having comorbid conditions which are absent, so you should go very tight. And establish vascular complication, if it is not there, if they are not there, you go very tight. But in the presence of a comorbid condition, you go not so tight. You have a moderate kind of hyperglycemia, because this is which we have learned from the ACCORD trial. Because intensive group, they have the more increased mortality in those patients. But the population they selected in the ACCORD trial, they were elderly people, more than 60 years of age. They have multiple comorbid conditions. And patient attitude, the expected treatment efforts, highly motivated patient, then you must go very tight, and you have the more stringent criteria. And if the resource in a sport is there, obviously you go very tight. So these are usually not modifiable, these are modifiable. So our notation has been proved wrong. You cannot have the A1C for everyone less than 7%. If the young person is there, without the comorbid conditions, you go for even less than 6.5%. So what is the new in the guidelines? So there are certain things by the year 2022, we have so few new things which has been added. So what they have done, the screening age previously recommended by the ADA was 45 years age. Now they are recommending the age of screening should be 35 instead of 45. So this is the new thing about this screening this year. So if you have 35, you include the 35, obviously your predictor you have more people to be inducted in the diabetic cohort. So second thing is, this is second, managing the risk of morbidity co-complication. Previously, the people were thinking if you control the blood glucose level effectively. So their approach was glucocentric approach. Their approach was not to deal with the complication. Now people are focusing more on to deal with the comorbid conditions, like if you are having they are saying that you must screen the person for chronic kidney disease, and you must see the patient, the person is having atherosclerotic cardiovascular disease. So we have two players in the market, either SGLT2 or along with metformin GLP-1 agonists. So they have a very profound role in managing these two comorbid conditions. So obviously confidence of practitioners to opt the new options. So these, because the help of these two modalities which are there, so our job has become more easy because we are addressing more effectively with the chronic kidney disease, heart failure and atherosclerotic cardiovascular disease. The role of CGM is becoming very popular. So people are using TIR compared to the HB1. Although this instrument, the gadget is quite expensive, might not be in use by so many practitioners, but I think very soon you will have in the market, the people are monitoring the blood sugar level, and they will be using the terminology like time in range, time above the range, time below the range. So gestational diabetes, obviously you have more strict screening criteria, and technology's influence, because majority of the people, they are using the WhatsApp, social media. So the role of social media and the other technologies has become more obvious and became more popular. So this is the basic class comparison. How they are different. I just summarize what are the treatment modalities which are available, what are their characteristics of the treatment modalities. First of all, the biguanide metformin, oral, A1C reduction 1 to 2%, no hypoglycemia, weight loss is there, and cost is very cheap. SGLT2, increased urinary glucose excretion, oral 0.7 to 1% is A1C reduction, hypoglycemia risk none, and weight loss is there, and the cost is a bit expensive. GLP-1 very expensive, either you give oral preparation is not available in Pakistan, but it is available I think by the year 2024, and A1C reduction 0.5 to 1.8, and no hypoglycemia, weight loss is reversed, and you have the cost is, I think it's $4, not the $4. DPP-4 inhibitors, oral, A1C reduction is there, no hypoglycemia. The things which are down the track are sulfonylurea because of risk of hypoglycemia and weight gain, and similarly the insulin analogs or human insulin, they have more hypoglycemia risk, and the weight gain is there, and they're quite expensive. So these are the few characteristics of the treatment modalities which are available. This is the ACE guideline. I will just briefly go through it. It is not based upon what are you having, but it is totally simply based upon the एंटरिंग A1C का, आपका A1C जब आपका पेशेंट आपके पास क्या था, उस पर आपने कैसे चलना है. If your A1C along with A1C at the end time of the entry is less than 7.5%, you start with the monotherapy. Either you go for GLP-1 or SGLT2 along plus metformin. Obviously metformin is there, but I think the role of metformin is again, and वो भी under fire है आजकल. If your A1C more than 7.5%, so you start with the dual therapy, or you can start with triple therapy. But if your A1C, baseline A1C is more than 9%, you can start dual therapy or triple therapy. But if there are other symptoms like patient is losing weight, and you can start, a patient is having glucose toxicity, you can start straight away with the insulin if your A1C is more than 9% from the day one. So to combat the hyperglycemia. So what they think about the insulin, the ACE guideline, what they think about the insulin. So they think if you start with the basal insulin, everybody who is having oral failure, you start with the insulin. And very interestingly, if your A1C is less than 8% and total daily dose, you can start with the 0.1 to 0.2 unit per kg. If your A1C more than 8%, your starting dose, total daily dose should be calculated with the formula 0.2 to 0.3 unit per kg. So this is the start total daily dose. So you target the fasting first in the basal insulin. We call it triple F regime. Fix the fasting first. But if your A1C is more than, if your fasting is more than 180, so your starting dose should be the 20% of the total daily dose. उतने यूनिट से शुरू करना है। लेकिन मैं एक सिंपल फार्मूला यूज़ करता हूँ 1 2 3, इसको उल्टा पढ़ लें 3 2 1। On every third day you give the increment of 2 units till your fasting drops to 110. So this is the simple formula you can remember, easy to remember. But similarly, if your things are not getting under control, you can add the prandial insulin, either basal plus. Basal plus का मतलब कि basal insulin के साथ एक prandial insulin, और एक से फ़र्क नहीं पड़ता मेजर मील के साथ, फिर दूसरी, फिर तीसरी, तो then you ultimately you end up with the basal bolus. So this is the new guidelines by ADA. This was previously it was ACE guideline, the ADA guideline 2022. So देखने में बड़ी कॉम्प्लिकेशन लग रही है, मैं इसको थोड़ा सा बड़ा करके आपको दिखाऊंगा तो उससे आपको थोड़ी सी चीज़ें क्लियर हो जाएंगी. But you can see you start the first line therapy, obviously glycemic management risk comorbid condition, and generally you start with metformin and comprehensive lifestyle modifications, metformin plus comprehensive. But consider combination therapy कि पहले दिन से मेटफॉर्मिन और आपने लाइफस्टाइल पे नहीं चले जाना, लेकिन अगर आपका A1C मोर देन 1.5% ज़्यादा है आपके डिज़ायर्ड लेवल से, यू स्टार्ट विद द कॉम्बिनेशन थेरेपी फ्रॉम द डे 1. पहले दिन ही 2 दवाइयाँ मिला लेनी है आपने, बजाय कि आप मेटफॉर्मिन के फेल होने का इंतज़ार करें उसके बाद दूसरी आप दवाई ऐड करें. So if you A1C above the 1.5% target, you start with additional. So but very importantly, you see these 3 things. थोड़ा सा मैं डिटेल में जाऊँगा इसके. फर्स्ट लाइन थेरेपी, ये जो मैंने भी बात की, कंसिडर कॉम्बिनेशन थेरेपी इफ द A1C above the target value. Reassess and modify the treatment every 3 to 6 months. So this is the main slide, and very very important slide. And nowadays, if your patient is high risk indicator for established atherosclerotic cardiovascular disease, अगर उसको दिल का पेशेंट है, दिल का मरीज़ है या हाई रिस्क पेशेंट है, यू स्टार्ट विद 5 मिनट्स रह गए हैं, मुझे 10 थोड़ा सा दीजिएगा, मैं थोड़ा सा पर काइंड परमिशन ऑफ चेयर पर्सन मैं उनसे इजाज़त ले लूँगा. मुझे पता है कि थोड़े इसमें जल्दी क्विक करूँगा. बट यू स्टार्ट विद द GLP-1 SGLT2 विद प्रूवन कार्डियोवैस्कुलर बेनिफिट्स. So if the things are not under control, for example आपने SGLT2 से स्टार्ट किया, फ़र्क नहीं पड़ा तो GLP-1 से, लेकिन GLP-1 हर किसी की रसाई में नहीं है. Everybody cannot afford the GLP-1. So you have the other option as well, we'll discuss. But if you are having heart failure at the baseline, पहले atherosclerotic cardiovascular थे, and the patient is heart failure. Heart failure भी 2 किस्म का है. कितनी किस्म का है? किसी को पता है कितनी किस्म का है? कौन सी 2 किस्में हैं हार्ट फेलियर की? हार्ट फेलियर विद प्रिजर्व्ड इजेक्शन फ्रैक्शन, हार्ट फेलियर विद कि जिसकी इजेक्शन फ्रैक्शन 40 से ज़्यादा है. अगर 40 से कम है तो रिड्यूस इजेक्शन फ्रैक्शन है. तो 2 मेजर क्लासिफिकेशन है. इफ द पर्सन इज हैविंग हार्ट फेलियर, स्ट्रेट अवे स्विच द पेशेंट टू दी आफ्टर द मेटफॉर्मिन एंड लाइफस्टाइल to the SGLT2 inhibitor with the benefit heart failure. And if the patient is having chronic kidney disease, बहुत सारे मरीज आपके पास आते हैं, 50% पेशेंट आते हैं आपके पास CKD के साथ, तो CKD plus albuminuria you go for SGLT2, and if the things are not under control you can switch to the GLP-1 and later on you can have amend the treatment accordingly. But एक और अदर क्वेश्चन है आप सब लोगों के लिए, अगर पेशेंट SGLT2 से भी उसको फ़र्क नहीं पड़ता या इंटॉलरेंट है, उसकी यूनिट ट्रैक इन्फेक्शन होता है, तब क्या करेंगे? तब क्या करेंगे? बट यू वांट टू कन्वे द बेनिफिट्स. अनदर प्लेयर इन द मार्केट, फिनेरिनॉन. फिनेरिनॉन इज अ न्यू कंपाउंड which you can add in place of SGLT2 with the similar cardiovascular and renal benefits. But if your preference is hypoglycemia, so this is the group DPP4, GLP-1, SGLT2, TZDs, and if you are thinking about the weight loss, GLP-1 or SGLT2, and if you are thinking cost, then you go for SU and TZD. तो पाकिस्तान में सारे उसी तरफ ही सोच रहे होंगे कॉस्ट, तो sulfonylurea and TZD. But also you know the effects of TZDs, they are very effective, very good medicine, but your problem is that you have the edema and the weight gain with those medicine. But if the things are not under control, just mention start insulin. Start insulin. Insulin, ये मैं जो कह रहा हूँ start insulin. Do you agree with my statement? जी? First injectable therapy should be insulin. Agree? No. The first injectable therapy should be GLP-1 if the patient can afford it. GLP-1 is the first injectable therapy if the patient can afford. Very soon you will have the oral GLP-1, but if the patient can afford, the first injectable therapy should be the GLP-1 prior to the insulin. But if the things are not available, obviously you will switch to the basal insulin. So you can start with the NPH, you can start with the glargine or thing like this. तो मैं इसकी डिटेल में तो नहीं जा रहा. ये बड़ी इंपॉर्टेंट स्लाइड है. When you are using insulin, can you use with metformin? Yes. But if you are using TZD, can you use with insulin? Because you will have more weight gain, and stop TZD when commencing insulin or reduce the dose. When you are using sulfonylurea, can you use it with insulin? Sulfonylurea? नहीं करना चाहिए. You can reduce the dose of insulin. And considering stopping sulfonylurea if the prandial insulin is there. अगर आप उसे short acting दे रहे हैं तो फिर तो आपको stop करना पड़ेंगे. But SGLT2, obviously you have weight loss with it. They are beneficial effect. And be aware of decay, euglycemic decay, यानी normal blood sugar पे भी decay हो जाता है SGLT2 के साथ. And DPP4 inhibitors जो बड़ी common गलती करते हैं, जो हमारे सारे कई डॉक्टर्स करते हैं कि DPP4 inhibitors दे रहे होते हैं GLP-1 के साथ, which should not be used. दोनों को combine नहीं करना चाहिए. So cardiorenal concern, what is a concern? अभी मैं थोड़ा सा quick करूँगा इसको थोड़ा सा. I will just take few minutes. Why we are giving more importance to this cardiorenal? So what are the game changers? Can you name the two game changers in this regard? SGLT2 and GLP-1, the two game changers. They have changed the whole scenario of diabetes management. So if the atherosclerotic cardiovascular disease is predominant, heart failure CKD is prominent. So how this is the mechanism of action, how the SGLT2 they act. They reduce the blood pressure, they induce the diuresis, ketone body metabolism, suppression of the sympathetic nervous activity, how they act the beneficial effect on the heart. So if the atherosclerotic cardiovascular disease is there, obviously you start with GLP-1 with proven CVD benefits. I will not go into details, but this is the EMPERACT trial. हमें ये कैसे पता चला कि ये वाकई benefits हैं? तो EMPERACT trial, it was conducted in the empagliflozin, so it has led to the 38% risk reduction of CV death, 35% risk reduction of hospitalization with heart failure, and 32% risk reduction of all-cause mortality. CV death is very, very important for in case of the EMPERACT trial, which we have learned, and you can see the Kaplan-Meier curve that you have the diversion of the curve from even from the very beginning. दूसरे तीसरे महीने इसका फायदे आने शुरू हो जाते हैं, but this effect you will not see with the GLP-1 because it will some few months to have the effects because it's acting on the other way. And this is the effect on the kidney. The red line say the deterioration of the kidney functions are less with the empagliflozin usage. So this is the lesson which you will learn. This is the EMPEROR reduced trial. जो मैंने बात की कि heart failure की दो किस्में हैं. Heart failure with reduced ejection fraction. What we have learned, 25% risk of CV death and hospitalization heart failure, and 30% risk reduction total hospitalization due to the heart failure. So this is in case of reduced ejection fraction. जब 40% से reduced ejection fraction हो तो आप जब use करते हैं तो ये benefits you can get. Even this line is very, very important. Empagliflozin can be initiated with the EGFR more than 20 पे, यानी जिसका EGFR 20 पे है उस पर भी आप शुरू किया जा सकता है. और ये इफेक्ट उन पेशेंट्स में भी है जो नॉन डायबिटिक में भी है, यानी these drugs has been SGLT2 been used in those patients who are non diabetic when you're treating the heart failure. So EMPEROR preserve trial, जिनका ejection fraction 40 से ज़्यादा है, these are the benefits you get. Primary outcome है जो CV death जो है 21%, हार्ट फेलियर की हॉस्पिटलाइजेशन 27% और रीनल फंक्शन जो है आपके GFR वो भी इसके साथ बेनिफिशियल है. डिक्लेयर ट्रायल ये डेपाग्लिफलोजिन पे है. दे हैव द सिमिलर रिस्क रिडक्शन CV डेथ, 35% risk reduction in heart failure, 32% reduction in all cause mortality. So this is DAPA in the heart failure. So these are the benefits which you get. ये इधर प्लेसिबो है, ये इधर डेपाग्लिफलोजिन वाला है. These are the benefits which you are getting. किडनी डिजीज़ पे इसका बड़ा अच्छा इफेक्ट है. 39% risk reduction when you are using डेपाग्लिफलोजिन in the patient with a chronic kidney disease. DAPA CKD trial के अंदर DAPA CKD trial has shown the all cause mortality 31%. So what are the side effects? Genital infections, urinary tract infections, osmotic diuresis, hypovolemia, hypotension, and rare diabetic ketoacidosis, amputation. Canagliflozin के साथ कहते थे होती है, लेकिन वो उसका भी नेगेटिव आ गया. Possible increase in fracture because bone necrosis, increase in bladder cancer. This has not be proven pancreatitis. And incretin therapies, ये GLP-1 receptor agonists जो which are available over here, dulaglutide, liraglutide, lixisenatide in combination, and semaglutide. This is the mechanism of action of the GLP-1. They act on the different pleiotropic effects on the brain, GIT, pancreas, kidneys, adipose tissue, liver, and muscles. These three are available: liraglutide, semaglutide, and dulaglutide, available in Pakistan. And this is the new chap in the town. ये है FDA approved the Lilly's Mounjaro tirzepatide, which is both GLP-1 and GLP-1 receptor agonist for the treatment of adult with diabetes. This is a new thing which is not available right now, but soon it will be available. And this is the last slide, but it's a very, very important slide for the management. अगर आपके पास resources limited हैं, तो आप कहते हैं जी मैंने patient को manage करना है, वो कैसे करना है? ये मैं थोड़ा सा बताता हूँ. If this is a eubolism, यानी कि normal metabolism. If your maladaptive anabolism, जब आप सोचते patient मोटा है, phenotype is overweight, obesity, high blood pressure, dyslipidemia, पैथोफिजियोलॉजी प्रीडोमिनेट्स इंसुलिन रेजिस्टेंस, यानी एक पेशेंट ओबीस है, ओवरवेट है और उसके साथ ब्लड प्रेशर भी है, डिसलिपिडीमिया भी है. इट मीन द पर्सन हैव इंसुलिन रेजिस्टेंस. चॉइस इज आइदर यू गो फॉर GLP-1 और SGLT2. बट ऑन द अदर हैंड इफ द प्रीडोमिनेट इज कैटाबोलिज्म, फिनोटाइप इज थिन, build, cachexia, osmotic symptoms are there, pathophysiology predominant, insulin deficiency, you go for the insulin and insulin secretagogues. And this is when you have the very limited, so you can decide from the phenotype of the patient which treatment you are going to have it. But this is the take home message. Individualize the treatment, very, very important. Every patient is a different patient. Management objective should be to reduce the long-term complication like CVDs and CKD. And newer agents like SGLT2 and incretins now make it possible to reduce the cardiovascular mortality and morbidity. The most important message is please first do no harm. Thank you very much for your kind attention.